Good evening to all. Thank you, sir, for introduction our team. On behalf of the Standard Interoperability Lab, PDL, we are honored to share our experience decisions at the AHIN webinar today. Our presentation today will focus on our experience from the past year using the DHIS2 tracker to improve the immunization data accuracy in Laos, and how this work will be set the foundation for the FHIR-based data exchange and the border health information exchange implementation in the future. I will begin with the overview of the digital health law context. The Digital Health Strategy Plan 2023 to 27, approved by the Minister of Health. The outline 37 strategy projects group under 5 pillars, like workforce, government standards, applications, and infrastructure. Based on this priority, the seal Laos paid a clean loan in operating for this activity. Our laboratory is the structure under the Health Statistics and Informatics Center, Ministry of Health, Laos, and bring together the IT experts like health specialists and the partner from the university, government, and private sector, and developing partners such as the WHO, ADB, World Bank, or HISP Vietnam, and so on. We focus on the capacity building, system developing, and research to drive digital transformations in healthcare in Laos. Yeah, for this slide is the illustrate our future reason for our laboratory, because our laboratory is under the Ministry of Health. Maybe is the different with the other laboratory. So that we will ensure the national alignment with the health priority and strategic goals, as I have mentioned previously, so that we try to specialize and learn like a collaborative components such as the certified enterprise architecture or certified open SAE expert, and also the health system developers will be responsible for the building, customize, and maintain the system like EMR, laboratory or radiology information system, and mobile health application. Also, the policy and research, we also include in our priority, because we would like to develop the national digital health policy, and also the monitor implementations and generate the evidence for the continued improvement. The system is the exchange or integration will be work across the platform to connect various digital health tools, such as like a DHIS2 and the EMR, so that we will present our work today. To achieve this goal, we will together with our partner, as I have mentioned before, focus on the sustainability and the local ownership and standards based on development. So this is that's all from me. For the next sections, my colleague Sam and Billy will present our 1 year progress using the DHIS2 tracker in the immunizations program, and also to provide the lesson learned and challenges. And the last sections, I will talk about the FHIR integrations for the patient data center or the patient data home in Laos. It is our next plan, but we hope that this webinar will give the feedback and recommendations. So that I would like to hand over to my colleagues to dive into the technical implementations and finding. Thank you. Over to you, Sam.
Okay, Dr. Thep, thank you so much. Hope you can hear me, and good afternoon or good evening or good morning to everyone. And first of all, I would like to thank you, Dr. Thep and Ehin, for this opportunity for us to present our work. Like Dr. Thep mentioned, Laos just celebrated the first 1-year anniversary of the EIR implementation. So the Ministry of Health, especially the minister, also joined to celebrate and highlight these great achievements. And before I start, I would like to also mention that this is a collaborative work with many groups of people, namely the government of Japan and UNICEF and Gavi for the funding and technical support, and also WHO Laos Country Office for the field work and or the implementation in the field, and with us HISP Vietnam on the technical and the system as well as the digital tools, and MOH and the National Department Immunization Program from MOH. So, okay, so maybe I would like to start just to share with you in terms of both on the implementation part as well as the plan, and then hopefully we will talk about how we can link with other information systems. So yeah, I will start with why Laos is moving to EIR, and then spend some time on how we implemented the EIR and just a bit on the future. So I will start with why. So for Laos, we have been using DHIS2 for almost or more than 10 years. And immunization program is one of those. And they were using or reporting on the aggregate report. And so far, they started using, really adopted DHIS2 in 2016. And as you can see, and in 2000 or end of 2023, they started to explore how if we can move or scale or transition from aggregate to case-based or this EIR electronic immunization registry. But before that, just to show you how immunization in Laos or the situation in case of the Penta 3 here, the coverage, as you can see, for the last 9 years. So they were not doing bad, they were doing quite okay. And if you know that our target for Penta 3 for Laos is on 95% coverage. And if you can see from the chart here, so only 2 years on 2018 and 2023 that we achieved the target. The rest is quite below, but it's not far. But when we look at by province, you can see that many provinces, they really achieve the target, but a few provinces that they receive more than 100%. And there are also many provinces that were not doing that great. And I think that's part of it is also on the aggregate reporting system, because in the aggregate reporting system, the facilities will report what vaccine or how many vaccine they gave every month. And then in terms of immunization, in case of Laos, children can get vaccine from anywhere, right, according to their convenience. And if you can see, maybe some provinces like in Vongphachan, or the one that achieve more than 100%, is there are some possible that there are children from neighboring province that receive vaccine here. So that's why they get more than 100%. But what I would like to highlight here, because of the aggregate report, I think for Laos, it's already reached the limit. So if we want to further analyze data to see the to pinpoint the issue or to reduce the gap, is very difficult, because the aggregate, you can only see the numbers, but when you want to really trace the child or to understand the situation better, it's very difficult. That's the first one. The second one, if I think this situation is also similar in many countries. Like we will have different logbooks, and the logbook in case of Laos, we will have logbook per village, and each village will have at least more than one logbook, because they will have the in facilities and they also have the outreach logbook. As you can see the picture on the left, that's the maybe from one health center that they have to maintain this a big pile of logbooks, and when they do outreach, they have to carry that as well. But then when you look into the details, you can also see that it's very difficult for the health worker to do data consolidation. If you can see the vaccine, they will just write down the date that the child received the vaccine, and when you want to aggregate by month or by year, it's very difficult. And if you want to try to follow up with the child, it's also not easy. And the last part is on Laos, because in many programs, they are also using DHIS2, but it's more on the program focus. One of the reasons, or the graph that I showed here, which I will explain later on the plan for Laos. So if you can see, in case of Laos, every program will have their own record. For example, the child here. So if the child is delivered in a delivery ward, the child record will also be recorded there, and hopefully they will have this ID or the number. But then when the child comes for vaccination, the same record will also be collected at the immunization ward, and he be given the immunization ID and etc. for nutrition, maybe OPD, IPD, same for facilities. The facilities that have good EMR or can afford EMR, they will also have their own kind of patient record and with their own ID. And with these three, and linked to what Dr. Thep mentioned on the digital health strategy. So this is what MOH is trying to move away or transition from this to be the person-centric, which I will discuss more. So with these three, in terms of the limitation, in terms of the how to make life of health worker easier to report, and how to use the system or digital solution better to serve their work, they decided, and along with Ministry of Health direction, they want to move to individual record. So as I mentioned here, because many programs or Laos or minister already adopted or made a decree that DHIS2 will be at least the data reporting for Laos. So every program or every health program should at least report some sort of data to DHIS2. It can be aggregate or some program that can do event or tracker. And like the case of FHIR or the EPR or immunization, because they started with DHIS2, then transitioning from FHIR is not that difficult, I would say, because for DHIS2, for some of you already familiar with DHIS2, they have a big community led by the University of Oslo and HISP Center. So HISP Center, they work with many organizations, especially UNICEF, WHO at the global level, to come up with the standard package for many health programs. Immunization is one of that, so they will define how the immunization program, if you want to use DHIS2 to implement immunization, what are the standards, what are the form or dashboard that you can use. And that's what Lao did. So we also explore how the package that we can use in Lao, we have a look, and then the program also analyze and decide, right? Because some of the program or the elements in the package that they are recommended by the WHO, but some are not suitable for Laos. But that's the good part, right? We can customize and remove or hide some of the things that we don't need. And with immunization, they don't have only immunization, but they don't have to have the birth part as well. And if you can see on the last part, the global package also made it ready for the system to be able to communicate with other system. In this case, in many countries that use DHIS2, they also work with the ECRVS system. So it allowed when we adopt this flow, then we are also doing the same thing that to connect with the ECRVS. And if you can see the design, they will have different vaccine and the age, and these are the standard configuration from the global. But as I mentioned, we can just customize to suit Lao country context. And with that, they also can be used with the web or the Android phone. So without much customization, these are already ready to be used. And it comes with the dashboard as well, so that we all have the standard set of dashboard that can be used to analyze the data once we have data in. So that's what we did. We explored the package and we also work with the National Immunization Program that DHIS2 can be used for electronic immunization record. And these are the things that it can be done. So they also spend quite some time to try to test and to experiment, and then decided maybe we can try to pilot in one province, and now that we already scale to all the facilities in Laos and just celebrated the 1 year. And when the decision is made, these are still few prerequisites that we need before we starting to implement EIR. And that will lead to a more integrated health information system. So the first one, what we did work with many departments is that we need to have a standardized facility list. With facility list, then we need a village list as well, because for immunization and many programs, because we will shift right from reporting from the facilities to village. We have the address, we know the address of the child, and doing data analysis, doing the gap analysis can be done easily. And then in terms of the report, which I will talk more, that there are some limitation on the aggregate that we cannot analyze the data by population catchment. So once we have those facility lists and villages at least standardized, then we also link like how many villages under one facility catchment. Then the next step is also important. So now that everyone will use the same immunization registry, then we should have a one ID. So in many countries, they can start with one program, but in Laos, since many programs are using DHIS2 and many programs are moving to more individual recording. So it's essential that we establish, and MOH already established this health ID, and they are using client health registry that's built on top of DHIS2 to issue this ID and distribute to all the children when they come for vaccination. And lastly is on the clear SOP, because moving from aggregate to individual in terms of workflow, it will require a slight shift of the workflow, and then the SOP is also revised. And now coming back to the aggregate system, right, when we want to say, because this is the difficult part when we want people to change from the already doing well system to another system that the fear of losing data or data might be missing. So we assure that, okay, because this one is really easy to replicate using DHIS2, right? So if you record the number of child or the detail of the child, then at the end of the day, not just DHIS2, but any digital software should be able to do that. And that is the role of digital system, right, to help the life of the user to make it easier. And that's what we said. Yeah, so don't worry, it can be the same. And so this is the standard report that we can do. So it's very similar, but I think it's more user friendly. They also have this color and all, but I will talk to show you more. So once they are sure that, okay, at least they can see what they are used to. And that's why they decided to pilot in one district. So in one district, we also advised with the support from the WHO to remove this logbook, or at least stop using it and use one logbook. So the new logbook is designed for to be used for the AIR. So no more logbook by the village, and also what you need, you just need kind of a daily record. So it's in Laos, but more or less it's more like you will just record this child is the new client or the new child or has never enrolled in the system or not. If that, you just circle, and then if you have the ID, you can write it down with names, with all the demographic details and the vaccines. And then by the end of the day, they can just enter this record one by one into the system, and the system will produce all the report or the necessary report that they need. So then when we did the pilot, we tell them, okay, stop using this, try to use this. And in terms of data entry is similar to this logbook. Like this is the interface of DHIS2. So it will ask you the first name, last name, sex, date of birth, and once you already enter all the profile, the ID will be generated, and you can and health worker can record that down into the logbook as well as the book of the child. And once the child is enrolled or registered, the next part is just which vaccine, right? And many following or few following information. In case of Laos, we would like to know about the fixed service, or this is the outreach or mobile. And in case of coverage, right, because some of the child, they can receive the vaccine from other facilities, like I showed you previously, can get the vaccine from the neighboring province. And in case of Laos, many people also go to neighboring countries to deliver and to get the vaccine. And here the health worker only just to select few of those, and which vaccine they will just tick and then save. So if you compare to before, it's much easier. And lastly, once they finish, they can also add a scheduling for the next round of vaccination. This can be done on time or real time, or maybe after before the day ends. But if you see closely on the right, yeah. So this is important, how they give the ID back to the child, so that next time the child can, the health worker can know the ID of the child and search the record and enter. But so in Laos, we have this, we call it pink book, to give to the mother. So the mother will carry this pink book. Then this pink book will contain the information of her children. And if she has more than one children, they will have different IDs here. So then the next time when the mother comes with the baby, she will bring this book and give to the health worker, and health worker will use this ID to search and to update the vaccination. And that's it for data entry. So once the data entry is finished, and with the next round of appointment, the system will record that and can remind the health worker if the next vaccine is due. So that's for the data entry. I think we'll mention more on the achievement that now instead of keeping track of many logbooks, they can just search and then enter what vaccine that provided, and then don't have to worry about counting and making the report. Now move to data use. So once they finish all of that, so there are many type of data use that they can do. And most of the thing I will show you on the report, but they also have the dashboard that they can monitor. So just to show you some of the real report that people are using. So this is the first one. If you remember, it looks similar to the logbook, but in the digital format in DHIS2. So DHIS2, after the end of the day, it can calculate, consolidate, and pull out this record for the health worker. So if they want to see by children, they can use this report, and it will show them how many vaccine, maybe for this selected the year. So many children that receive vaccine in this facility and in this year. And as you can see, then they will also see when the date is when the vaccine is given, and with different colors as well. And most importantly, now they will have the phone number and the ID, which I will mention more. So in terms of the color, right, and here is for them to easy for the health worker to be able to distinguish. For example, in this case, the purple is to highlight that this child is getting this vaccine from outside of the country. They have many colors different on the place of vaccination. So in case of central hospital or provincial hospital, they will have different color. But for vaccine that they give in these facilities, it will be white. So this is one of reports that they can do. The second one, if they want to see the aggregate, they can still do, right? That's the beauty of the digital software. So every month or every quarter or every year, if they want to generate the report that they used to do by hand, they can also use the system to produce this report to maybe to see and maybe to give it to the higher level. But the most important, and I think is the highlight of using the digital software and for moving to electronic immunization record, is that now the system can tell you, right, if you have any appointments, especially for health facilities that have many children under their catchment. So they can run the report to see how many, like for example, like this month, how many children that I expect to come for vaccination, or in case maybe they missed or they forgot, we also have this overdue, right? So it will show you, okay, this month maybe how many child forgot or how many children that their parents forgot to bring for vaccination. And then in terms of increase the coverage, the health worker have access to also phone number that they can call to the mothers or the fathers or the guardians to, okay, that please bring your child for vaccination, etc. And lastly, on the report, like I mentioned in the past, when they use aggregate, it's very difficult to see the report by catchment, right? Because you can only see by facilities. People come for service at facilities, and then they will do aggregate and give the report. But then it's very difficult, right, to know if the child in your catchment is getting vaccine somewhere else or not. So that's why now moving to EIR, because we have the address and we also know the facilities, this report can be calculated and is better for them. So like here, you can also tell the system to produce this kind of report, right? Like, okay, you can also see how many children in your catchment receive the vaccine, but then you can also break down, okay, so maybe how many people, how many children or how many percentage from outside or from other facilities. And this is what make the coverage better, and in terms of following up with the children, reducing the gap or even the zero dose is very easy to, or easier for them to do, or to follow up. And it's also helped with the province where their children usually go to the neighboring province for vaccine. Right? It can be because maybe the service in the province is not that maybe it's not enough, or they don't have the vaccine in the province, and children go to other province for vaccine. But they still can get the report, and they still can track and also know that if, okay, to be sure that the children in the catchment at least got the vaccine. Okay, now I would like to come back and highlight all the achievement, and also there are some challenges that we still need to work on. So in terms of the achievements, in terms of data quality and management, this is I think the big one, right? Because the team successfully reduced or stopped using that big pile of logbooks, and to have just one, or in case some facilities they still keep two, one for their facility and one for outreach. For them, it's easier to report, but at least we get rid of that, and then they don't have to worry about when they want to make the report. So they just enter the data what they wrote on the logbook, and then the system will do all of that. And in terms of data quality and errors, is too soon to tell, but we can see that it's improving significantly. Then in terms of the impact, we also started to analyze in terms of the dropout rate. We also see that it's slightly reduced, and cannot confirm, but we also think that now, because we have the mobile phone number, like I showed you, health worker can easily contact to the parents if the child is missing some vaccine. And lastly, since now we have the ID, we have the information or the details of the child, it's easier to link with other system. And in case of ECRVS, that now we can also share the newborn child with ECRVS, and ECRVS can also share the same data to us to complete this record. And of course, there are some challenges, especially on the internet connection. For Laos, there are still small percentage of health facilities that don't have internet access, or very limited internet coverage. So they still need to keep the way they do. And then at the end of the day, usually district will help them to enter the data to report. And there are still some data quality and data use issues. And in terms of data use, still limited because it's new, and it will require some time for the health worker to adjust and how to rely on system to follow the child. And like I mentioned, in case of the outreach, sometimes when health worker go for outreach, they will go for several days and collect many information. So, and when they come back, they have to spend quite some time to enter data, and in some facilities that they might take longer time to enter all those records. In terms of the data itself, we still have challenges in the case of Laos. So usually newborn child will not have the names. So it's quite a challenge when you want to register that child. And even with the parent's name, in the remote area, people still collect only nickname, or just to keep nicknames to the health worker. And most of the time we can see that they don't have the family name, which is quite will be a challenge when they want to reach out to the parents. And lastly, like I mentioned, there were some hesitation and resistance at the beginning, but since we do the phase Y, and people start seeing it is really helping, and the own way or the own record is not missing, and then at the end of the day, the team managed to scale up to the whole country. And the last part is about linking with other systems. Like I mentioned, Laos is at the stage of doing this program we call program centric. Each program will have their own record and own ID. But now with EIR leading the way with many. Now we can have one ID, and the same ID can be used in many programs, right? And since they are using DHIS2, and it's easier to link the record. So we just mentioned about immunization, but that's the next plan is to expand, right? Immunization, if we think about immunization, it's just one program, but when we shift to the patient or the person is the child, and the child is, they can have many stages of healthcare. So vaccination is one of that. Now we have monitoring, we have then in case of sick child, we also have that. And now we can have one program with many stages, like we have birth, we have immunization, we can also follow up on the growth monitoring using the same system to not having to register the child again. And in case you know the birth happened, then you can directly share that with immunization program so that they can continue with immunization, so reducing the gap of missing the child. And currently it's like this, but my colleague, I think, will mention more on how the integration. But for now, this is inside DHIS2. We have another one on CHR that will link all this program with one ID, and then we'll create a patient profile, and then it can be further linked with many programs. Okay, so I think that's all for my part. I know it's a bit, there are many things to talk about, but have limited time. I hope you have some idea, but if you want to explore more, or you want to know if the similar thing can be worked in your area, feel free to reach out to me or to Dr. Thep. Yeah, thank you. And over to you, Billy.
Hello again. My name is Billy. I'm a consultant from ADB, currently working on implementation of the pilot HIR7 FHIR server. So this is the first time in Laos that we try to create the FHIR system to be the to support the future data exchange in Laos. So why we need the HIR7 FHIR in Laos? Now in Laos, there are many digital health systems that are using right now, like the DHIS2, and also the BAMI, which is the hospital management system, are currently in piloting. And there are many hospitals in Laos that using the hospital management system. So the problem is the data between those systems are siloed, and it had limitation. It had limited interoperability. Some of systems try to exchange data each other, but it's more like a system A exchange with system B. So it's just developed in that specific case. So it doesn't have any standard in terms of exchange the data in health system in Laos yet. So the HIR7 FHIR provide a way to structure and standardize the data exchange. That's why we use the HIR7 FHIR. Our goal is to build a unified person-centric health information ecosystem. So what is HIR7 FHIR? HIR7, which stands for Health Level 7. It is an organization that developed the health data standard. The FHIR stands for Fast Healthcare Interoperability Resource, which is the newer version of HIR7 that support the latest web technology like RESTful API or JSON. So it is easier for developer to develop this version instead of the older version. Also, FHIR are resource based. It has many resources like patient encounter, immunization. This is the standard way that we can correct and store the data. So just a little bit recap about HIR7. I think everyone might know about this already. So what we are working on right now, we are developing two core systems. The first one is a FHIR server system. And the second one is report system. The FHIR server will based on FHIR, which is the open source. So we don't need to pay for the license. This server will include the API gateway that will pull the data from many sources like DHIS2 or BAMNI or other hospital management system and other system. Then the data will pass to our mapping service, which will convert the raw data from those servers into FHIR resource. And finally, it will store in FHIR database. And the second one is report system. This system will pull the data from FHIR server using RESTful API and then transform those data into our custom report schema. And then it will save to database, which is the broad-scale. Then we will use Metabase, which is the open source BI tool that will integrate with that broad-scale, so it can visualize the data and make report for us. This is the architecture overview. We have many data sources like DHIS2 and other system, and it also have security and load balancer to handle the request, and also to secure the data for when we exchange data between service. And data processing will process by via messaging layer, such it is a RabbitMQ and also HTTP protocol. The storage, we use FHIR server for SCADKL for database. And we also have caching layer, which is Redis cache for the better performance. This one is just take a look in each system that we are making. The first one we call is API gateway. This system will pull the data from other source like DHIS2, BAMNI, and other source, and then it will store that data just in the raw data into the database. And then it will notify to RabbitMQ, which is the message broker. So when this system notify to message to RabbitMQ, the other system will know that there are the new data available. So it can pull the data from here, like this server. This is a mapping service. When it know that it have new data available, it will pull the data automatically and then transform the data into FHIR resource, and then send those resource to save in FHIR, and it will integrate with a PostgreSQL database to store the data. So this is our HR7 server, and the next, this is our report system server. It will start with this server. The ETL server will pull the data from FHIR application using API, and then it will transform those data into the report database and store the data to PostgreSQL database. This one is just for reporting only. It has adapt the schema to compatible with Metabase. Then we will use Metabase to integrate with this database, and then we can use Metabase to as a report too, and create report here. So this is just the overall of our system architecture. So to make this work in Laos context, we need to map the data from the DHIS2 first, since this is the biggest health system that being used in Laos. There are many modules in the DHIS2 like EIR, IPD, MCH. We need to integrate all of them and then extract the data from them to store in our FHIR server. So for EIR, we can get many resources from here, like the child and the mother will be the patient record, the vaccine type and other will be immunization, and we can also get observation resource, and it will translate into these FHIR field. So the same for the IPD, we can also get encounter condition and other resource. Also the same with MCH, we can get the mother data to patient, and then it's also translate into the FHIR field right here. So that is just to recap to explain about how we integrated the data from the DHIS2, and this is for right now, this is just the only one system that we are currently developing and integrating data with. Next one, this is about our report system. Right here, we have designed the database schema that compatible with Metabase. Since we cannot join the Metabase directly to the HL7 file because the data is too complicated. So we had to make our own schema first, and then use develop and then we make the service to pull the data from HIR. It will get the HL7 standard data, and then we transform the data here before store to the PostgreSQL. Then this is the Metabase. We then integrate the Metabase to the PostgreSQL, and it can do many things here. Like it has function to X-ray or the table available in the database, and it will suggest the interesting data for us automatically. And we can also create our own reports, our own custom report too in the Metabase. And this is the interoperability diagram. So instead of let the other system to get the data from the DHIS2, we try to make the HL7 as the middleman. So for example, if there is a hospital system that wants the patient data from the DHIS2, that system can integrate with HL7 FHIR, and it will get the data that in form of FHIR resource. And when that system want to register new patient, they can also exchange the data, register to our server, and then our server will sync the data with the DHIS2 instead. By doing this way, MOH staff that are currently using the DHIS2 can also get the new data, and those two system data will be synced and update every time. Achievement so far. So right now everything is under development. The HL7 FHIR server and also the report system scheduled to host the test server within this month, and also the Metabase, which is the report system, will host in the test server within this month. The implementation timeline on May, just like I say, we will host the test server within this month, and on June we will implement the authentication layer. So to support the external service that want to get or exchange data with the server. On July, we will try to implement the FHIR-centric that I just mentioned this one. And on August, we will deploy everything on the production server and prepare to hand over to MOH. So for the summary, right now we are making HL7 server, which include two systems, the server and the report system, and everything now is under development, and we plan to deploy and hand over it to Ministry of Health in the end of 2025. Yeah, so that's it for the HR7 server. Now I want to hand over this to Dr. Thep to continue the session. Thank you.
Thank you, Sam and Miri, for your presentation. I think we have done the same from outside, so that's the based on the question. It is the Q&A question, right? Sure.
Yes, so thank you, Dr. Thep, Sir Sam, and Sir Billy. I think all of the questions in the chat box have already been answered as well. Oh, sorry. I think we have a minute left and there's just one question.
Over to you, Miri.
So the last question is, did you consider using CQL?
Yeah.
Yeah, for right now, from now until the end of 2025, the main focus is just to extract the data from the DHIS2 and then display those data to the database. That's it for our plan. So currently not yet for the CQL.
Yes, thank you, Sir Billy. I think we can proceed with wrapping up the session. But before we go, maybe we can hear a few words from our chair, Dr. Bunchai, or maybe Dr. Alvin.
Thank you, Charis. Thank you, Dr. Thep, Billy, Sam. You're doing great work. So we wish you all the support. We are always here. We have experts in the coil, and we know that you also have local talent over there. I think once we are all together as a community, supporting each other's capability, we will be the thing that our country needs. So I'll pass the floor now to Dr. Bunchai.
Thank you, Thep and the team. Congratulations, you have doing the great job. I hope that many of you from Laos already registered for the FHIR Foundation, right? And just to inform our community that Laos and had reached out to the SEAL Thailand to kind of the support for the implementation. Dr. Rat also working all of these collaboration. The ADB also support Laos with to get reach out to SEAL Thailand. So we will working together on this. Great job.
Thank you, Dr. Alvin and Dr.
Could you
Bunchai.
close?
Thank you, Dr. Bunchai. And so with that, picture with the community.
All right. Thank you, everyone.
Thank you. Take care. Good luck, Dr. Thep and team. Good
Thank
night.
you. Bye.